Basically, what I usually describe is you have a standard chest tube in which you have a G-wire, which we all use in medicine, with a loop, and that you can have it travel up and down the chest tube to make sure you break up the clots, and to make sure again that the end, which you don't see inside, the end of the chest tube will always be patent. So you will usually, and we actually came up with the first protocols, but usually what we do, we will make sure that the chest tube is clear the first 15 minutes immediately after the operation. Actually, we check it in the operating room as we put it in. We check it once the patient is in the bed to make sure everything's functioning. And then, sequentially, we decreased. If the patient is bleeding a lot, you can do it every 10 minutes, 5 minutes, as needed. But then, for the first 24 hours, we came up with an empirical protocol to space it out. So basically, mechanically breaking up the clots, making sure that the tube is patent, that's the mechanism of it. Pretty simple, but you have to think about it, and it's very, very efficient. So you decrease the incidence of chest tube clogging, which I'll show later, is 1 out of 3 chest tubes are clogged the morning after. So they're not doing their job. The standard chest tubes are inadequate.
So FlowGlide was the first physical change to our first generation product, which was invented by our surgeon founder. And we made the improvement because we wanted to achieve some advantages in use that we knew had not been achieved in the first design. For example, when the curvature of the device is very narrow, when the bend radius is narrow, the friction coefficient increases, which means that the magnetic coupling sometimes can struggle to navigate around a tortuous chest drain. FlowGlide coating reduces the coefficient of friction very dramatically, and it means that our device can be placed in much more difficult situations than before. For example, behind the heart or in the left pleural space with a curvature. So that was one benefit. But the nature of the coating also is very biocompatible. It's antithrombogenic, and because of its biocompatibility, it discourages tissue ingrowth. So at 2 days or 3 days, the tube removes very easily. The tissue does not stick to it. And of course, the benefit of biocompatibility, antithrombogenicy, is that it also reduces the likelihood of wound infection, we think, around the insertion site. So we see a number of benefits from FlowGlide, and of course, as we explore more regions to use active clearance technology, we think about where is retained blood a problem. In fact, not just blood, where is retained fluid a problem? And so our ambitions for the future, if I could say it in a kind of tongue-in-cheek way, is to become a human waste management company. We want to remove blood and fluids from all kinds of different environments in the body where they could be a problem. There is no reason why we shouldn't have active clearance technology for cranial catheters in the head, for example, or abdominal catheters after large general surgery, like liver procedures, or large bowel procedures, large gynecological procedures, anterior spine approach orthopedic procedures, and even, frankly, in the joint capsule, the hip, the knee, and the shoulder, where those surgeries take place. Retained blood in the joint capsule is inflammatory. It causes thickening of the tendons. It increases rates of infection. It reduces motion for the patient over time, and there's a benefit there too. So the high-level ambition for our company, of course, is to provide enhanced recovery after surgery. This is another society which is embracing our technology. Of course, we want to do that, but we're looking farther afield to how waste management, fluids and blood which is lost after the initial procedure, should be effectively disposed of and not left in the body. Your body can deal with it, doesn't like doing that. Especially if you're sick, if you're old. When you leave waste products in the body, it puts an additional tax on the patient. It makes it harder for them to recover, it lengthens their recovery time, and that becomes more costly and more inconvenient. And in fact, when we follow these patients for longer periods of time, the patients who have retained blood problems, like pleural effusions or pericardial effusions, they have numerous other problems that the cardiac surgeon may not see. They return to work later. They have higher rates of clinical depression, and we know that because one of our researchers in Canada follows the prescription drug pattern of these patients at 1 year, and the rate of prescription drugs for depression in patients who have retained blood complications is higher. which is natural. If you think about it, after your surgery, when you go home, you want to get back to work, get back to your normal life, to cooking, playing golf, whatever you do. If that's delayed and you feel sicker, of course it affects your mental health as well. So retained blood, I mentioned earlier, is a root cause in the acute phase, in the ICU phase, but post-operatively, it also is of benefit to make sure that the patient is treated properly at the beginning. Children don't have large thoraxes, and so the conventional adult-sized tube has too much real estate to fit inside the small chest. Of course, you can manage it with coiling the tube, but then the device may not work properly. So at the request of the pediatric cardiac surgeons especially, we shortened the tube so that you only have to put a little bit of the tube in the patient's body, and in a few months we'll also shorten the outside of the tube too. So the two systems together will be a very compact, children-sized edition. But today you can use the adult cleaning system with what we call the shorter effective drainage length tube for pediatrics. It has fewer eyelets, which means that you only have to put a small portion of the tube in the patient's body, and the largest portion of it remains outside. And that means that you don't put the large tube unnecessarily around the organs in the body of the child.